Is it an MSO structure? Is there employed docs versus network docs? Give us like another minute or so for those who are a little further along in this reading around the structure of risk delegation and how yours is organized.
Sure. So I work with all of the above. So a market gets split up based on the extent of the financial relationships that exist in the market. You mentioned MSO, which is like ACO, the largest in this area is Delaware Valley ACO, for example. And Cigna actually has their own ACO called Care Allies, who I work with very closely. But there's like a security wall between the two because of the way that the finances flow. So they have their own medical director, but I work with their medical director and their teams for some aspects of how they're doing. Then there is sort of your big groups that have public health teams, essentially their own population health teams. So when you think about Jefferson Health, Penn, Temple, they have, Mainline, they have a population health team that is working with payers. And those are sort of my counterpart roles. So those are the people that I would work with. And then we have kind of our own value-based performance for quality. And then we have those doctors, depending on their size. I don't, just because of the size of the market, I don't usually do like one-on-one with some physicians. But if it's a big enough practice, we would. And if there is kind of opportunity for growth with a practice, we would meet with them and talk about it. But those are sort of the different scales of engagement. And our goal as a payer is to have engagement and have a relationship with the physicians to really help with stars and risk adjustment and really think about how to kind of share that revenue, essentially, because it really benefits everyone. And I think that's one of the things that I talk to that people are most resistant about in terms of a payer. They're like, well, you're giving us this deal that we can't bonus on. And you're like, trust me, all I want is a deal where you can bonus on, because that means we all get a lot of benefit out of it, right? Like, yeah. So that's kind of the breakup. And I work with all of those different groups, and I have to be very comfortable in terms of contracting language. It comes up all the time. And working with the contracting teams, they'll say, can we do this? Can we not do this? And I'll provide the clinical input if it's like a realistic thing or not, if it's going to be something we could measure or not, right? Just because something is a good idea, it doesn't mean you have good data to measure it later on. And that makes it very difficult to enforce even a good idea in a contract.